Our first speaker is Dr. Thomas Wiest. He is CEO of Ulcer Solutions, LLC. Thomas is currently he practiced orthopedic trauma surgery for over 25 years in Eugene, Oregon, and was the president of Slocum Orthopedics for over a decade. And he earned his master's in medical management degree at USC and is a fellow of American Academy of Orthopedic Surgeons. He serves as an advisory observer and board member for several health-related startups. Welcome, Thomas. The stage
Thank
is
you.
yours.
Thank you. All right, let me share my screen and get going. All right, everybody see that okay?
Yes.
Perfect. All right, Yuli, thanks so much for your introduction. And similar to a lot of other folks on the call, this is always a fun little gathering, and I appreciate being able to present to colleagues. I will start off with the fact that this will probably be the lowest tech, but potentially highest impact speech of the day, because it doesn't have anything to do with AI, doesn't have anything to do with digital medicine. It has to do with taking care of patients with pressure injuries. So I'm the CEO of Ulcer Solutions. Most of that was covered by Yuli in my intro, and I believe these go out and recorded, so all the links are there if you need to contact me for any of those other endeavors. So this is the problem that I'm talking about, and this is heel and ankle pressure injuries or bed sores. And although those are relatively small wounds, this is a big problem. There's about 3 million of these that occur annually, over 11 billion spent on treating pressure injuries. And the big thing for those in acute care, and it's probably the worst acronym in healthcare, HAPI, HAPI, which is a hospital-acquired pressure injury. And anyone who gets a HAPI is incredibly unhappy, and especially the hospital administrators, because that's a Medicare never event. And this is actually data that's about a year or two old, but it's upwards of $40K for a hospital to eat if someone gets a hospital-acquired pressure injury under their watch. And so these expenses are driving facilities to take a little bit more better care of their patients, to be more well-positioned to avoid those costs. And the aging of America and a lot of the hospital at home movement and a lot of the home health care folks, and certainly the extended care facilities, deal with this problem all the time. The biggest problem is the current solution stinks. Most of these are these bulky foam or plastic or fabric boots with straps that go across the anterior tibia. And the boots are poorly tolerated by patients, almost universally hated by nursing staff and patients alike. And in some early clinical survey studies that our founder, Dr. Christopher Finley, did, he found that 40% of his patients refused to even take the thing out of the box. And essentially 100% failed to wear them as directed. The average time they were worn was only about 8 hours a day, which seems reasonable. I mean, a reasonable workday. But when you're treating a pressure injury, there's two things that are really important. One, effective relief of the pressure, and effective relief of the pressure for as long as possible. And these boots just don't do it. They're hot, uncomfortable, bulky, a fall risk, and are universally despised. So Dr. Christopher Finley, a wound care specialist up in Vancouver, Washington, he's an ER certified doc, started taking some shifts at the wound care because ER work was burning him out like most ER docs. And all the patients in his clinic who had heel ulcers were not getting better. And he asked them, like a good physician, he actually talked to the patient and said, "Aren't you wearing the boot?" And the answer was pretty much universally, "Hell no, I hate it." In fact, 40% of them never took it out of the box. And so these are comfortable. They offload completely. They are the better substitute for the current boots. And the bottom line is both patients and practitioners really like them once they get a chance to use them. So the heel keeper was his first invention. And as you can see from the picture on the right, the heel is 100% offloaded from any supporting surface, as are the malleoli. Really hard to get a pressure ulcer from air. And that's the only thing that these are exposed to. They're safe and easy to walk. They are narrow enough that it doesn't strike the other leg when you're ambulating. And also our design spreads out the pressure along almost the entire length of the calf, or at least 2/3 of the calf. And in fact, Heel Keeper 2.0 will be slightly longer to further dissipate the pressure. There's a cutout and a relief for the Achilles tendon, which is a very problematic place to be treating a pressure injury because of the paper-thin skin and exposed tendon in the wound. Patients can wear them 24/7. They like them because their feet are exposed. They're not hot, uncomfortable, or constricted or claustrophobic. And for the providers, it allows direct inspection of the heel and or ankle wounds, oftentimes without having the need to remove the device. Some other, quote, donuts are out there, but they are very narrow donuts, and some of those actually produce increased pressure over the site. And so our design is unique and fortunately patent protected. The second invention was the ankle keeper, which was designed specifically for a patient in Dr. Finley's practice who kept coming back with recurrent malleolar ulcers. And as most of you know, the malleolar ulcers are small but hard to heal, centimeter, centimeter and a half. And a patient comes in with a wound about the size of their thumbnail that's not getting better, and you hand them a big bulky boot and saying, please wear this, it'll make you get better. And you can imagine the compliance with those instructions. So this cushion is specifically shaped like a U or a C to milk the edema back to the heart. The donut type of constrictors actually hold the edema around the ulcer, and some can actually prevent healing as opposed to accelerating. It's designed for comfort, convenience, and compliance. You can wear most of your shoe gear. It's a very inconspicuous, exceedingly light device, and many patients wear them 24/7. Our third product is currently in prototype, and literally as we speak, we've got 5 or 6 of them farmed out to various manufacturers and getting some quotes back. It still provides 100% offloading of the heel and ankle. The heel is still free floating because there's recess built into the foot plate, and the malleoli are free floating, as you can see in the picture. The beauty of this device is it's convertible. For those that need the plantar flexion support or avoid plantar flexion contracture, i.e., nursing rehab, neuro rehab, ICU, paralyzed patients, etc., the foot plate is there to allow that. But then as the patient transitions and they still need heel or malleolar protection, it converts back into the normal heel keeper. And we think with the foot plate, it will be reimbursable, and we can jump on some HCPCS codes that already exist for that. And here it is in action. Simple little Velcro release, and out comes the tab, and then it converts into the regular heel keeper. You can remove that for dressing changes if necessary, and then it slips right back in. Simple closure, and bingo, you're right back to the HK-AFO. Elegant, simple, and it works. So as I mentioned, the story was physician-founded by a doctor who saw patients who weren't getting better with a specific problem, and the market solution was not acceptable. And so we're a physician-owned, physician-found, and physician-run company, which immediately makes us patient-centered. And we're dedicated to really producing the new gold standard in pressure injury prevention and treatment. Our team's pretty darn strong. Chris Finley is our founder. That's me there. Al Cochran took a couple pharma companies to NASDAQ. John Naputi, our CFO, also took a couple companies public. And our compliance director, Rich Wincoop, has a long history with FDA, and he manages our QMS programs. Some very small clinical findings. The traditional boots in the light purple are heel keepers in the dark. N of 25 for the heel keeper and a 53 for the boot. The patients wear them 63% longer. The traditional boot, as I mentioned before, patients tolerate it for about 8 hours. Our device, they're in it at least close to 14. And the longer you're relieving the pressure, the higher likelihood the wound will heal. And this one is the clinical research on refusing to wear. And you can see moving from left to right, even on the most left-hand column, again, heel keeper dark, traditional boot light. There's folks that 10% of the folks said, sorry, I don't care how cool that heel keeper is, I'm not wearing it anyway. And it's 6 to 10 hours of use. Again, very little resistance to using it. And then the percent of patients that wear it with the duration of 12 to 17 or 18 to 23 hours, you can see the heel keeper dwarfs the regular boot, basically 2 to 1. So you're getting literally twice the potential for healing wearing our device as opposed to a traditional boot. And patients who have the opportunity to wear both, 80% prefer the heel keeper, 7% jump on the boot, 13% says, you know, I don't like either of them, and so I guess I'm going to have to put up with my ulcer. In national and international wound care conventions. A poll was taken of 129 wound care experts at attendees with the question, would you recommend the heel keeper, ankle keeper? 89% said they would, 11% said, I need just a little more information to decide, but 0% said no. And this is a combination of between physical therapists, nurse practitioners, wound care specialists, wound care nurses, plastic surgeons, podiatrists, foot and ankle surgeons, and all spectrums of care from acute, ICU, all the way to home health. We've got defensibility. We've got a utility patent on the heel keeper based on the shape and pattern of the injectable foam. We amended and updated that filing this year. We're waiting to hear back from that. And both the ankle keeper and heel keeper have utility patents pending. This is the competition. Hot, bulky, sticky, straps over the shin that can produce additional pressure. And which one would you prefer? That or the elegant solution on the right? Experts like it. Desmond Bell, who's president of the Save a Leg, Save a Life Foundation, a wound care specialist and podiatrist who's exited a couple companies in this space. He wore it 24/7, and there was times when he said he forgot he had it on. A nurse with 4 decades of experience thought it was one of the best things offered. And these 2 patient quotes are nice. I mean, one extolling the beauties of the ankle keeper, the other of the heel keeper. But what I find most impactful is the last sentence in both of them. I began wearing the heel keeper, and now I wear it every night. My wound healed quickly, and I still wear the heel keeper nightly. So even after they're done with their course of care, the patients still use them for prevention. Physician-founded, physician-led company. It's time for a new gold standard. Patients and clinicians love the products. And I'm up to my 10 minutes. I got more information in the appendix, but happy to take a little bit of Q&A. Yuli, really appreciate the time. Thank you.
Thank you, Thomas. Okay, it's time for questions for Thomas. Please raise your hand if you want to ask a question, and we'll unmute you and get you on the microphone. All right, Margaret Wong, go ahead, ask your question.
Yeah, hi, Dr. Lewis. I just wonder, what is your reimbursement?
If you mean, is there reimbursement for the product under health plans? The answer is 0, because there is no reimbursement for preventive measures for wound care of any type. Our somewhat perverted healthcare system pays for intervention, but doesn't pay for prevention. We think we will get HCPCS coverage on the HKAFO as long as it's written for the proper indications, i.e. preventing a plantar flexion contracture. You can't, I mean, if you provide it for someone who just has a heel ulcer because you know you get reimbursed for it, that would, of course, be a fraudulent activity and recommended to be avoided. I don't anticipate trying to get a HCPCS code for prevention. Many have tried, all have failed. It's also about a 3-year process. And the last 2 out of 3 that I have heard of, what CMS came back for reimbursement didn't cover the cost of goods.
I see. And what would you price, let's say if I have a patient, what will be the price to purchase this? Obviously, it's out of the patient's pocket.
Yeah, it depends where and how you get it. We are in the final, hopefully, week or 2 of negotiations to get onboarded with McKesson. So we'll be part of their distribution system and their formulary very soon. If you want to purchase it, go to our website, www.ulcersolutions.com. And the direct-to-consumer price is around $60. Our distributors obviously get a better margin than that, and we have a full volume-based unit cost. So we can go anywhere from about $29.99 up to about the list price of $65, depending on volume.
Great, thank you.
And, you know, HSAs and health savings accounts can be used for these products.
Right. Ravi Kamipalli has a question. Ravi, go ahead, unmute yourself.
So looks like a good product, my friend. I mean, like the way I see, I use this offloading heels as a part of my.
We lost you there, but I was hoping I'd get a question from the wound care specialist.
I know. That's what I was hoping. Well, let's hope he'll come back.
Yeah.
If any other questions for Dr. Thomas here.
Sorry, I guess my Wi-Fi went off. Basically, what I want is 60% of them don't put it on like they need to put it on. And my hope is that this product will solve that issue. But my question also was the cost amount for, say, hospital systems. Is it comparable to the cost of the other boot companies?
Yes, it is. I mean, the price point we kind of hear battered back and forth between distributors and especially the very price conscious extended care facilities is if you can get it to me for $30, I'll probably use it. And we can hit that mark and still do okay. We have a volume based. I think if you order 1,000 or more, it's $29.99. So it's quite reasonable. And if we're shipping to some of your folks in India, it might even be less because our current manufacturers are in that neck of the woods as opposed to the United States. So shipping costs to facilities in India, Australia, New Zealand, et cetera, are less because our distributors there take them directly.
Great. Yeah,
Well,
I'm here. I'm in Atlanta. So
thank you very much. Thank you. Shelley has her hand raised.
Yeah. Hi, Thomas. A great presentation. Just
Thank
a
you.
real quick question. I'm wondering, how has your fundraising experience been? Can you share anything about that?
Sure. Right now, we're funded solely by individual qualified investors, myself included. Currently, we're doing okay. We've got 6 months of run rate in the bank, and our Amazon presence. I mean, my job when I was hired as CEO a little over a year ago was to take it from a mom and pop direct to consumer presence on Amazon and Shopify and start playing with the big boys and girls in med surg distribution. And I'm a week away from getting McKesson on board. Owens and Minor is next, and we'll move from there. But right now we got 6 months of run rate in the bank. If you're interested in investing, the minimum is 25K. 50K gets you 1% of the company, and we can certainly entertain offers higher than that. And we're, just like any startup CEO, jobs 1, 2, and 3 is fundraising, and then business development. So anyone on the call, feel free to reach out to me, either a direct message through the LinkedIn. I'm happy for Yuli and the organization to give away my business email, which is very simple: tweast@ulcersolutions.com.
Thank you.
You bet.
With that, thank you very much for sharing your innovation and also, explaining how it works.